Welcome back, class. We are working today on airway management. Remember that this is chapter 10 in the 11th edition, so pay attention to that in your workbook. The title we're working on, airway management. The single most important step we have in caring for patients is to address life threats, and a primary component of that step is making sure they can breathe adequately. When the ability to breathe is disrupted, oxygen delivery to tissues and cells is compromised. Cells require a constant supply of oxygen to survive. Some of them require more continuous supply of oxygen. Some of them can do a little while without some oxygen. Within seconds of being deprived of oxygen, vital organs like your heart and the brain, they'll stop functioning normally. Brain tissue, for example, will begin to die within 4 to 6 minutes without oxygen. Oxygen reaches the body tissues and cells through two separate but related processes: breathing and circulation. During inhalation, oxygen moves from the atmosphere into the lungs. Oxygen then crosses the alveolar membrane and attaches to hemoglobin by a process called diffusion. Hemoglobin is found on our red blood cells. Red blood cells carry the hemoglobin and therefore oxygen through the body, ultimately delivering it to the capillaries to oxygenate the body's cells. At the same time, carbon dioxide, produced by the cells in the tissues of the body, moves from the blood into air sacs by diffusion. This carbon dioxide is basically a waste product. So your body uses the oxygen and returns carbon dioxide in its place. Oxygen enriched blood is then pumped through the body by the heart. Carbon dioxide leaves the body during exhalation. And as an EMT, you must be able to locate the parts of the respiratory system, understand how the system works, and recognize which patients are breathing adequately and which are not. The figure on this slide illustrates the upper and lower airways of the body. As we move farther in this, you will see, we'll talk more in depth about each of those sections. So the respiratory system consists of all the structures that make up the airway and help us breathe or ventilate. And remember, ventilation is the mechanical process, respiration is the metabolic process. The airway is divided into the upper and lower airways. There are structures that help us breathe. That includes the diaphragm, which is that large muscle at the base of the costal margin, which is just attached to the lower ribs. The chest wall muscles, those are all of the muscles that line all of our ribs. Accessory muscles of breathing, which include our upper muscles around our neck, our back muscles, our chest muscles, our pectorals, nerves from the brain and the spinal cord to those muscles. So specifically, we have the ability to control respirations, and additionally, our brain has the ability to control those respirations without our input. The anatomy of the upper airway include the nose, the mouth, the jaw, the oral cavity, the pharynx, and the larynx. And we're going to break down a few of those just a little bit more. The main function of the upper airway is to warm, filter, and humidify air as it enters the body. The membranes, the tissue, etc., if that becomes dried out, then it doesn't function correctly. So it is important for it to be humidified before it enters the lower airway especially. The pharynx is a muscular tube that extends from the nose and the mouth to the level of the esophagus and the trachea. It's composed from top to bottom, as we've discussed before, of the nasopharynx, the oropharynx, and the laryngopharynx. Naso meaning nose, oro meaning mouth, and laryngo meaning your larynx, your voice box. The nasopharynx filters out dust and small particles, warms and humidifies air as it enters the body. In the nasopharynx, you'll notice on the very top, you see those little areas that allows air to pass over. So it's a greater surface area, allowing it to humidify it. Additionally, you have a lot of hair in those areas that capture things like dust as it's coming up through the nose. This is also where, whenever you get a cold or you have allergies, those areas get a little congested and they swell, which then makes it hard to breathe, and you sound very nasally. The oropharynx is the posterior portion of the oral cavity. The epiglottis, which is a very important structure that you can't see in a picture right here, but we will in a future picture. But that helps prevent food and liquid from entering the larynx during swallowing, which is very important. Some of us override that, maybe while we're talking, or as we get older and the epiglottis gets a little floppier, then it becomes easier to actually choke on food and water when we're trying to breathe. So I'm going to try to use my pointer mouse here really quick. Oops, I'll go back and I'll just point out to you a few of those structures. Let's see. I know they're in here somewhere. Nope. Nope, I don't want to go that way either. I think there is. Oh, wait, here we go. There's a laser pointer. All right, so we're just going to point out a few of these structures related to the oral pharynx, just superior to the laryngopharynx. Okay, so here we have the entrance into the oral cavity. Back here is where the oral pharynx is located. Now, if you look to the anterior view, you'll see back here, right, is where our adenoid, or not our adenoids, but our tonsils are. Our adenoids are actually high up here, and in most adults, they're actually flat now. Our tonsils become inflamed whenever we're experiencing some type of an infection or maybe some type of like a strep bacteria is affecting those areas. And this, of course, is the uvula. Um, the epiglottis is this floppy structure right here. And whenever the person swallows food or drink, it serves to collapse and fall onto the trachea, which then allows food and materials to bypass the trachea and go into the esophagus, which is great because we all know what happens when food and water happen to find their way past the epiglottis and into our trachea. It makes us cough significantly. And of course, we have the soft palate, the hard palate. The soft palate is a bunch of soft tissues. Um, all right, so and the tongue, of course, is a large muscular organ in the oral area and extends all the way down to the oral pharynx where it meets up with the epiglottis. And gingiva, of course, refers to the gums around the teeth. All right. The larynx is a complex structure formed by many independent cartilaginous structures. It marks where the upper airway ends and the lower airway begins. So it's at this junction at the larynx. That's where the upper airway ends and the lower airway begins. The thyroid cartilage forms a V shape anteriorly. The cricoid cartilage forms the lowest point of the larynx, and the glottis is the area between the vocal cords. Hold on, and I think there is. Look at this picture. Oops. There we go. So again, here's the thyroid cartilage. Makes that V shape. Here is the cricoid cartilage. And then right in the middle here is a special little area as you expand beyond EMT, possibly into paramedicine or even advanced EMT. There is a possibility that you'll learn to do a cricothyrotomy, which basically is inserting a needle into this area in order to create an airway that bypasses some type of obstruction in this area. And then below the cricoid cartilage begins the trachea. Now, the lower airway's function is to deliver oxygen to the alveoli. So it's basically just a pathway to continue humidifying and to continue to capture things that are icky that the lungs don't want to breathe in. So if dust makes it past the nose, for example, or smoke, which is more common usually in the summer months around here, So smoke makes it past, because it's such a small particle. It makes it past the nose. It doesn't get picked up. It'll get down into the bronchi, into the bronchioles, which also have what we call cilia, Cilia. Cilia is a fine hair that tries to capture, and in addition to that, you have mucus that's created along that cilia that serves as kind of a stickiness to that to anything that's trying to come through. So stickiness on the hair-like fibers called cilia, and then it captures those particles. And then as it captures those particles, it's preventing it from getting into the alveoli, where it could potentially cause even more damage. But now we understand. Okay, so now we know our bronchioles are irritated. There's mucus being collected in there because it knows that there's something that's irritating it, so it's trying to capture it. What do we have to do to get rid of it? We have to cough. So we start to cough, and we cough up phlegm. And depending on the exposure to whatever is irritating the lungs, or irritating the bronchi or bronchioles, will depend on what color that sputum is. If it's an infectious organism and it's inflammation, then it could be a greenish color. If it's smoke, it could be a yellowish color. All right, so the trachea, the conduit for air entry into the lungs. It's a long cartilaginous tube, again with the cilia and mucus production. Divides into the carina, which is that bifurcation between the two main stem bronchi, right and left. Right, so that's right where it branches off. And bronchi are supported by cartilage. Also, they have much thicker mucus production, less cilia. But if something gets into that part of the lung field, then it's gotten past a lot of defenses already. Small particles, again, like smoke, cigarette smoke, those are able to get into that bronchi region and even into the bronchiole region, and then ends up with thick mucus, trying to cough out some of that disgusting particle accumulation along the surface of the bronchi. Additionally, the bronchi are reactive in trying to keep things out that don't belong, and they'll become inflamed because of the irritation, and or because they're trying to protect the rest of the lung. And whenever they do that, then that's whenever you start to hear those wheezing sounds. So you'll hear wheezes because air is being forced between the mucus and the inflammation of the bronchi, and then trying to be forced back out again. Oftentimes, wheezing caused by bronchial obstruction happens, and their expiration becomes difficult because they trap air basically into the lung fields. So they bring air in, work of breathing, push air out, also work of breathing, but they're not able to push as much out as they are able to bring in. And then the bronchi, the air flows through the bronchi. Hopefully, it's open into the bronchioles, which are another smaller branch of the bronchi. It's just like a tree if you were to look at it, with the branches becoming smaller and smaller until it gets to that end terminal component of the alveoli. So bronchioles are made of smooth muscle. They dilate and constrict as oxygen passes through them. Smaller bronchioles connect to alveoli, which are one cell thick membranes, basically, much clustered together, much like a sack of grapes would be. Oxygen is transported back to the heart and distributed to the rest of the body. So whenever it gets into the alveoli area, it's one cell thick, filled with many, many, many capillaries that surround these alveoli sacs, and the fluid, or the blood, is pushed through these thin-walled balloon-like sacs on capillaries, and the exchange of oxygen and carbon dioxide take place by the process of diffusion. So oxygen comes in and has less carbon dioxide on the alveolar inside, and it passes through the capillary membrane that is um, carrying oxygen, or carbon dioxide rich blood, and has less oxygen. So as it's passing through, it's basically trying to balance itself out. So the carbon dioxide, or five on one side, one on the other, it's going to want to balance it out, throw a couple over on that side and keep some to itself. Same with oxygen. Oxygen is doing the same thing. It's diffusing across the membrane, You have a higher concentration of oxygen within the alveoli, and it needs to transfer over to the vessel. And so it sees that there's only 2 oxygen, and I have 6, so I'm gonna lend it 2 more, so that we can try to balance ourselves out as it's going by. There are a lot of physiological processes that affect the ability for that to happen, and we learn a lot about that in respiratory pathophysiology. Also to note, even though they're not necessarily part of the airway, they are contained within the thoracic area, and they are a major part of the airway and the lung field. So anything that affects the airway and the lung field in the thoracic cavity could potentially affect the heart and the great vessels, and vice versa. So if there's an issue with the heart, it potentially could affect the airway and the the ventilatory capacity, in addition to the great vessels. The mediastinum is the area between the lungs. So whenever we refer to the mediastinum, maybe talking about traumatic injuries that are affecting the mediastinum, and/or in X-rays, you may hear a doctor say the mediastinum is shifted to one side or the other. The mediastinum is that area between the lungs, and within that area is the heart, the great vessels, the aortas, and the vena cavas, the esophagus, the trachea, the major bronchi, and many, many, many nerves. So every nerve branching off from the spinal cord comes through that thoracic area and across that mediastinum into its appropriate areas. The phrenic nerve is also found in the thorax, and the phrenic nerve is specific to the diaphragm. It's an important structure of the nervous system, and it allows the diaphragm to contract, which is necessary for breathing to occur. So the respiratory and cardiovascular systems, they work together. One does not go without the other, and that's when we talk about in patient assessment that it is super important that if you have a respiratory complaint, that you're also doing a cardiac evaluation. And if you have a cardiac complaint, you should also be doing a respiratory evaluation in your secondary assessments. So they ensure together that a constant supply of oxygen and nutrients is delivered to all of the cells in the body, and removing carbon dioxide and waste products from the cells is an extremely important function. We always think about getting oxygen to the cells, but also very important is getting rid of the waste. Just to reaffirm the definitions, right? The physical act of moving air into and out of the lungs is ventilation. So that's that mechanical component. Oxygenation is the process of loading oxygen molecules onto hemoglobin molecules in the bloodstream. And respiration is the actual exchange of oxygen and carbon dioxide and the alveoli, as well as the tissues of the body. So any of those end components where oxygen and carbon dioxide are exchanged are referred to as respiration. So in this table, you'll see that we have defined again what ventilation, oxygenation, and respiration are. And we're going to continue to dive a little bit deeper into those. Right, so ventilation, again, the mechanical aspect of breathing. It is the active muscular part of breathing. The diaphragm and the intercostal muscles contract. The lungs require the movement of the chest and supporting structures to expand. Partial pressure means the amount of gas in the air or dissolved in the fluid. Oxygen and carbon dioxide both diffuse until the partial pressures in the air and the blood are equal. So that's that process I was just referring to, where carbon dioxide and oxygen are trying to find a balance between each other in the blood and the partial pressures of the air that's being inhaled. The mechanism of ventilation can be illustrated by using a bell jar. If we were to have one, it would be a great example. But it is important to realize that the thoracic cavity is a negative pressure container. You create negative pressure by contracting the diaphragm when you take a breath. That then pulls air through the least path of resistance into the lungs. So that path of resistance, the easiest part, of course, happens to be the trachea and the airway, the upper airway. Whenever you relax your diaphragm, then the diaphragm then pushes the air back out via the path of least resistance. Inspiration is focused on delivering oxygen to the alveoli. Not all inspired air reaches the alveoli for gas exchange. Tidal volume is an important word or a term to remember. It's a measure of depth of breathing, the amount of air in milliliters that is moved into or out of the lungs during a single breath. Tidal volume for an average adult is 500 milliliters. And is we're using our bag valve masks. That bag is typically between 500 to 1,000 mLs, depending on the manufacturer. The portion of inspired air that fails to reach the alveoli is considered dead space. So if you have a tidal volume of 500 milliliters, but only 400 milliliters arrive at the alveoli, then you have a dead space of 100 milliliters. Exhalation, unlike inhalation, does not normally require muscular effort. It is a passive process. It's the relaxation of the diaphragm that allows air to be pushed back out via the path of least resistance. The smaller thorax compresses air in the lungs into a smaller space. The air pressure in the thorax is then higher than the outside pressure, and then air is pushed out through the trachea. Air can enter and leave the lungs only if it travels through the trachea, if that is the only open path of least resistance. And when we talk about traumatic injuries to the chest, sucking chest wounds, this is when a hole in the chest actually becomes an easier path for air to come in and air to go out of the thoracic cavity when the diaphragm is working. Ventilation regulation involves a complex series of receptors and feedback loops that sense gas concentrations in the body fluid and send messages to the respiratory center in the brain to adjust the rate and depth of ventilation. The body's need for oxygen is constantly changing, and you guys know that when you start exercising, then your respirations become faster, and that's because your body has sensed, oh, I need more oxygen for my activity, so it will tell your body to start breathing faster. Failure to meet the need can result in hypoxia, which is an extremely dangerous condition. The tissues and cells don't get enough oxygen, and if it's not corrected, patients will die quickly, especially if the heart and the brain are affected. For most people, the drive to breathe is based on pH changes in the blood, and our normal pH is 7.35 to 7.45. Patients with chronic obstructive pulmonary disease have a difficult time eliminating carbon dioxide through exhalation. So they always have higher levels of carbon dioxide, and then that leads to a higher acidity within the blood, and it alters their respiratory center in the brain because gradually the respiratory center says, okay, well, if this is normal, then this is what I'm going to constantly try to keep as normal. So the body uses this backup system. It's called the hypoxic drive to control breathing. Use caution when administering high concentration of oxygen to these patients with obstructive pulmonary disease, because high concentration of oxygen can actually alter their backup system to the point that their body thinks, oh, I've got plenty of oxygen. I don't need any more oxygen. Now I'm just going to stop breathing. So then the patients then stop breathing because the body is trying to correct that too much oxygen situation happening. Now, of all of the patients that I've ever treated, I actually never had any patients that stopped breathing whenever I used oxygen because they were on too much oxygen. But it is something to be aware of. If you have a chronic COPD, their oxygen saturation is, at 89 or 90. That may be a normal oxygen saturation for them. You may not have to give them high concentration of oxygen, maybe start them or continue them. Usually they're on a nasal cannula at that point. Continue them on their nasal cannula and bump it up a couple of liters to see if the patient's symptoms are improved. Okay. And then patients with severe respiratory or circulatory compromise should receive high oxygen concentration no matter what, right? Regardless of their underlying medical condition. We're not going to look at somebody that's breathing at a rate of 32 and they're having a hard time exchanging air. You hear little, very little lung sounds accompanied by wheezing, inspiratory and expiratory. The patient is blue, maybe mottled, diaphoretic, and obviously is hypoxic. It doesn't matter if they're obstructive pulmonary disease and they're on oxygen normally or their 89% O2 sat is normal for them. This patient is in distress and is headed quickly towards failure, needs to have high flow O2. Early signs of hypoxia include restlessness, irritability, apprehension, a fast heart rate, and anxiety. And if you think about just diving into a pool, going deep down into the water and staying there as long as you possibly can, at least two of those symptoms will present themselves. And it's kind of that similar situation. They're drowning. They cannot get enough air. They are trying to breathe. Late signs of hypoxia, mental status changes, weak pulse, cyanosis, poor skin signs as far as sweatiness or diaphoresis. Conscious patients will complain of shortness of breath. You'll see the work of breathing that they're doing. They'll be breathing faster. They'll be using more accessory muscles to try to get air in or to push air out. The best time to give a patient oxygen is before signs and symptoms of hypoxia actually appear. Oxygenation is the process of loading oxygen molecules onto hemoglobin molecules in the bloodstream. So it's required for internal respiration to take place. If the hemoglobin have a problem and they can't hold on to the oxygen molecule, then you're not going to transfer oxygen into the respiratory component, which is the alveoli. So that oxygenation doesn't take place. It doesn't guarantee the internal respiration is taking place just because you're giving them oxygen. And then ventilation without oxygenation can occur, for example, in places where oxygen levels in the breathing air have been depleted, such as in mines or confined spaces. In respiration, the actual exchange of oxygen and carbon dioxide in the alveoli and in tissues of the body, cells take energy from nutrients through a series of chemical processes known as metabolism, aka cellular respiration, and each cell combines nutrients and oxygen, producing energy and waste products, mainly water and carbon dioxide. External respiration brings fresh air into the respiratory system, exchanges oxygen and carbon dioxide between the alveoli and the blood in the pulmonary capillaries. Surfactant is a fluid that keeps the alveoli open. Without surfactant, then those little membranous alveoli would actually stick together. Whenever fluid gets in there and starts to create stickiness in the alveoli because it washes the surfactant out, that's what that scratchy sound or that clicky sound is that you heard whenever we were discussing rolls the other day. So the rolls sound is the alveoli snapping apart because the fluid is washing away that surfactant and pushing up and into the lung field because of heart failure. Babies that are born too early sometimes are born without surfactant. And those babies then have a difficult time with respiration because their alveoli are not functioning as they should. Whenever a baby is born early, one of the first things that they'll do is to inject artificial surfactant into the respiratory system in an effort to keep those alveoli expanded. Additionally, if a baby is born early, they'll try to, or if they expect that the baby will be born early, they'll try to give the mother medications to advance the maturation of the lung field for the baby so that they'll grow faster, basically. By the time they come out, hopefully the lungs will have developed enough that the alveoli will work. Because ultimately, if they cannot fix the alveoli in an early term infant, the outcome is not positive. Internal respiration is the exchange of oxygen and carbon dioxide between the systemic circulatory system and the cells of the body. So oxygen passes from blood and capillaries to tissue cells. Carbon dioxide and cell waste pass from the cells into the capillaries, where they are then transported to the venous system back to the lungs. All cells need a constant supply of oxygen to survive. And depending on the type of cell will depend on how much of that oxygen is required to survive. Skin cells do not require nearly the amount of oxygen that is necessary to run a brain cell. Brain cells are the high functioning CPU, and they are very oxygen demanding. Time is critical. Without oxygen, 0 to 1 minute, cardiac irritability occurs. 0 to 4 minutes, brain damage is not likely. 4 to 6 minutes, brain damage is possible. And 6 to 10 minutes, brain damage is very likely. More than 10 minutes, irreversible brain damage occurs. When there is enough oxygen, cells convert glucose into energy through aerobic metabolism. Without adequate oxygen, anaerobic metabolism takes place, which cannot meet the metabolic demands of the cell. If this process is not corrected, the cells will eventually die. Chemoreceptors monitor levels of oxygen, carbon dioxide, hydrogen ions, and the acidity or pH of cerebrospinal fluid and provides feedback to the respiratory centers. The feedback may be need to breathe more, need to breathe less. Ventilation perfusion ratio and mismatch indicate that the air and blood flow must be directed to the same place at the same time. Ventilation and perfusion must be matched, and this is also noted by a VQ ratio. A failure to match ventilation and perfusion is the cause of most abnormalities of oxygen and carbon dioxide exchange. So either the ventilation is not working, the mechanical component is not working to bring enough air in, or the respiration component, aka the perfusion, is not working well enough to allow the oxygen and carbon dioxide to trade places. Whenever they are matched up, you're a normally functioning, non-ill human being. Whenever there is a misbalance and they are not matched up, then you don't work as well. When ventilation is compromised but perfusion continues, blood passes over some alveolar membranes without any gas exchange taking place. Results in a lack of oxygen diffusing across the membrane and into blood circulation. Carbon dioxide is not able to diffuse across the membrane into the lungs and instead is recirculated within the bloodstream, which can lead to severe hypoxemia. So compared to hypoxia, where we were talking about low oxygen levels, hypoxemia is very specific to low oxygen levels within the blood. Similar problems can occur when perfusion across the alveolar membrane is disrupted. Factors affecting pulmonary ventilation include maintaining a patient airway is critical. Intrinsic factors that can cause airway obstruction include infections that produce a lot of mucus and inflammation, allergic reactions where the body actually sends every open capillary into the bronchi and into the bronchioles and into the upper airways in order to prevent the antigen that's causing that allergic reaction from entering. Unresponsiveness, i.e. tongue obstruction, which happens to be the number one cause of airway obstructions. There are extrinsic factors that can cause airway obstruction, including trauma and foreign body airway obstructions. External factors such as atmospheric pressure and the partial pressure of oxygen in the ambient environment, most notably is in confined spaces where, like mines, where the oxygen concentration is not correct or the atmospheric pressure is incorrect. Also can include in high atmosphere or high altitude atmospheric conditions where the atmospheric pressure changes. Internal factors such as conditions that reduce the surface area for gas exchange and consequently decrease the body's oxygen supply that lead to inadequate tissue perfusion. So like pneumonia, pulmonary edema, and COPD emphysema. Obstruction of blood flow to individual cells and tissues is typically related to traumatic emergencies. Pulmonary embolism can be medical or trauma. Simple or tension pneumothorax typically is traumatic. However, simple pneumothorax can occur spontaneously in very tall basketball players. They're not always basketball players. We just assume that if somebody's tall, right, they're going to be a basketball player. But it is kind of a not completely common, but it is definitely a known potential for very tall, thin males to experience a spontaneous pneumothorax. An open pneumothorax, like a penetrating chest injury to the heart, to the thorax, and a hemothorax, which is blood inside the thorax, and a hemopneumothorax, which is air inside the thorax. So going back, pulmonary embolism is actually a situation where a clot or a thrombus stops blood flow to parts of the lung field. Simple or tension pneumothorax. A simple pneumothorax means there's simply air in the thorax and usually isolated to one side or one part of the thorax, where a tension pneumothorax actually accumulates to the point that it begins to shift the other organs within the mediastinum. An open pneumothorax means there's open air in the thorax. A hemothorax means there's blood in the thorax. And then, of course, the hemopneumothorax is blood and air within the thorax. Other causes of circulatory compromise include blood loss, anemia, hypovolemic shock, an abnormal decrease in blood volume, vasodilatory shock, abnormal increase in blood vessel diameter or decreasing blood pressure. Any patient suspected of being in shock should be treated aggressively to prevent further interruption to tissue perfusion. And we spend a whole chapter discussing shock all by itself. In patient assessment, it's important to recognize adequate breathing. Unless you're directly assessing a patient's airway, you should not be able to see or hear the patient breathe. Signs of normal breathing for adults, 12 to 20 breaths per minute. Regular pattern of inhalation and exhalation, bilateral, clear, and equal lung sounds, regular, equal chest rise and fall, and adequate depth, aka tidal volume. Whenever we do our assessment, we are looking to see that all of these components are normal. When they are not normal, we are looking for what is it that is abnormal? Is it that they're breathing too fast? Is it that the pattern is inadequate? Maybe an excessive inhalation and a decreased exhalation? Are their lung sounds affected? What about the chest rise and fall? Is it equal? And if it isn't, which side rises farther than the other? Which side does not appear to rise? And also, does it look like they're actually bringing in enough air? Is their tidal volume acceptable? An awake, alert adult who is talking to you usually has no immediate airway or breathing problems if they are talking to you in clear sentences. Always have supplemental O2 and a BVM or a pocket mask close at hand to assist with breathing if this becomes necessary. Signs of abnormal breathing include fewer than 12 breaths per minute, more than 20 breaths per minute, an irregular rhythm, diminished, absent, or noisy, auscultated breath sounds, and reduced flow of expired air at nose and mouth. Unequal or inadequate chest expansion resulting in reduced tidal volume, increased effort of breathing, use of accessory muscles, shallow depth, aka reduced tidal volume, skin that is pale, cyanotic, cool or moist, or diaphoretic, skin pulling in and around the ribs or above the clavicles during inspiration, aka retractions. A patient may appear to be breathing after the heart has stopped. These occasional gasping breaths are called agonal gasps. Cheyne-Stokes respirations are often seen in patients with stroke or head injury, and breathing with increasing rate and depth of respiration followed by apnea or lack of spontaneous breathing. I hope to have a good video on Cheyne-Stokes and ataxic respirations. Unfortunately, the videos from our last presentation have been taken off of YouTube. Ataxic respirations have an irregular or unidentifiable pattern and may follow serious head injuries. Patients experiencing a metabolic or toxic disorder may display other abnormal respiratory patterns, such as Kussmaul's respirations. Kussmaul respirations is so evident when you walk in and somebody is actually breathing in this very deep, rapid respiration. It's usually seen in patients in metabolic acidosis, very commonly with diabetic ketoacidosis. Patients with inadequate breathing need to be treated immediately. As soon as you recognize that their airway and breathing is compromised, that should be addressed absolutely right away. If you have a chance, take a look at this particular video. We will watch it in class, but it is here for you to refer back to. It's a great video. It shows you, it not only can you hear the different patterns of those breathing types that were just described on the previous slide, but it also has a visual for you to see. So you can actually see the pattern and how that translates into what the respirations are. So in your assessment of respiration, um, even though the patient may be ventilating appropriately, respiration can be compromised. Level of consciousness and skin color are excellent indicators of respiration, because when respiration falls and carbon dioxide and oxygen is not exchanging, then you have skin changes. They're going to be blue, they're going to be pale, they're going to be moist. Um, so even though the patient may be ventilating appropriately, the actual exchange of oxygen and carbon dioxide at the tissue level may still be compromised by several factors. You have high altitudes, poisonous gases, including carbon monoxide, which actually affixes to the hemoglobin, and oxygen is not allowed to attach. So hemoglobin shows up to the party. Carbon monoxide's already having a party. Oxygen's like, what about me? And they're like, we're not going to give you a ride home. Some EMS services carry handheld carbon monoxide detectors. And if there is a potential for carbon monoxide in the area that you are in enclosed space, in a garage, etc., you probably shouldn't be there. It's a scene safety concern. A patient's level of consciousness and skin color are excellent indicators of respiration. Again, when assessing patients, consider proper oxygenation, which can be assessed by pulse oximetry. So we carry these pulse oximetries. Again, if their skin signs are poor, you don't need to wait for a pulse ox in order to determine if they need oxygenation. If they are in obvious respiratory distress, you don't need to wait for a pulse ox to determine that they need oxygenation. Okay, but if you're treating a patient and getting a set of vital signs, you place oxygen saturation. And your goal is that, they're hopefully at 98 to 100%. Maybe they're not, but they're not in severe distress. And maybe they're satting at 92%. Our goal in EMS is to get them to 94%, unless they're in respiratory distress and or respiration at the cellular level looks poor, right? So if they're meeting all of the ventilation looks okay, respiration looks okay, they're satting at 92%, I think I'll go ahead and add a nasal cannula, 2 to 4 liters per minute, and I want to titrate that to an SpO2, a pulse oximetry reading of at least 94%. Okay. There's no specific threshold for normal values. Again, some people may be in the 89 and 90, and that is absolutely normal for them, in particular if they have some type of obstructive pulmonary disease. But also 96% in a non-smoker can indicate hypoxemia. So an SpO2 of 90% or lower usually requires treatment unless the patient has a chronic condition. Pulse oximeters can take as long as 60 seconds and have to be held still and not in sunlight in order to reflect changes in a patient's oxygenation status. Time delay is important because patients can develop respiratory insufficiency very quickly. That's why we're not relying on pulse oximetry to make the decision for immediate oxygenation in patients that are significantly compromised. It's considered a routine vital sign and can be used as part of any patient assessment. In fact, if you do get a pulse ox on somebody while someone is preparing oxygen treatment for a patient that is in obvious distress, you can document this was our first pulse oximetry reading at 88%. After high flow O2 at 15 liters per minute via non-rebreather, their pulse oximetry improved to 95%. So that's a positive finding and should be documented. But again, I can't stress enough, don't wait to give somebody oxygen so that you can get an accurate pulse oximetry reading before oxygenation in a critical patient that needs O2. Factors that can cause inaccurate pulse ox includes hypovolemia, severe peripheral vasoconstriction, like chronic hypoxia, smoking, hypothermia when they're super cold. Also, severe peripheral vasoconstriction occurs in septic patients that are in septic shock. Time delay in detecting respiratory insufficiency, dark or metallic nail polishes, dirty fingers, your homeless population, you may have to clean off their finger with some alcohol, hand sanitizer, or alcohol swab before applying the pulse oximeter. And then, of course, carbon monoxide poisoning, because again, it's just looking for hemoglobin saturation and it recognizes, oh, look, there's a molecule hanging out on the hemoglobin. So I'm going to read back it's 99% saturated. Pulse oximeters don't replace a complete assessment. They can't measure the effectiveness of your ventilation or provide information about metabolism. To assess ventilation, you'll need to measure the end-tidal CO2. And end-tidal CO2 is measured by capnometry and capnography devices. Emergency medical care begins with ensuring that there is an open airway. And again, if somebody is talking to you, their airway is open. Rapidly assess whether an unconscious patient has a patent airway and pulse and is breathing adequately. Airway and breathing are two closely related but separate components. Adequate breathing does not always equal an adequate airway. Position the patient correctly. The supine patient position is most effective in determining opening airways. Unconscious patients should be moved as a unit. Most common airway obstruction is the tongue. And as a result, we have a device that we can use to keep the tongue basically up off of the back of the oropharynx. Other causes of airway obstruction include dentures, blood, vomitus, mucus, food, and other foreign objects. If the dentures are out of place, they're not in place, then it is best to remove them, but do be cautious that you don't place them in a position to be damaged and also that they are protected. If the patient is at home, set them up on a counter or somewhere where they're safe and out of harm's way and can be found again later when they return home, hopefully. If the patient is out in public, package them carefully and ensure that they are provided with the patient's belongings upon arrival at the hospital. They're very expensive, and Medicare doesn't cover them. Blood, vomitus, and mucus in the airway need to be removed, and that's what we would use suctioning for. Food and other foreign objects, of course, that also has to be removed and may require that we use a recovery position in order to assist that out of mouth. The head tilt chin lift maneuver is the one that we use the most to lift patients' tongues off of the back of the oropharynx. So we tilt the head back, lift up the chin. If a patient has or is expected of having sustained a spinal injury, then we do what's called a modified jaw thrust. We don't do the head tilt chin lift because that could certainly exacerbate any type of spinal trauma. So during CPR, we cover the head tilt chin lift significantly. And again, the purpose of that is to lift the tongue off of the oropharynx so that the airway is completely open. The jaw thrust maneuver is if we suspect spinal injury or potential for spinal injury. We basically want to place our thumbs on the zygomas and the maxilla just above the upper teeth. And then we use our fingers to lift the mandible up and away from the body. Once the airway has been opened, assess whether breathing has returned very quickly by looking at the chest to observe for any obvious movement. If a patient is unconscious and this opens up their airway, be prepared to maintain that position for a long period of time. You can't just set the airway back down and think that it's going to be normal again. It doesn't work that way. Also, if the patient has fractures to the face, you'll have to maneuver the mandible or pieces of the mandible upward and away so that it can lift up the tongue. But ultimately, once that structure in the face is damaged, it does become a difficult maneuver. Even if the airway is open, the mouth may be closed. So you might have to open the mouth by opening with a cross-finger technique where you place your index finger and thumb on the patient's teeth, cross them over, and then open them up. And the reason you do that is it gives you the most strength than if you were just trying to pinch or grasp and push apart, right? So if you do a crossover maneuver, then you have a little bit more strength. I guarantee if somebody's teeth are clenched, it's very difficult, if not impossible, to actually open the teeth. So here's just a visual of performing that jaw thrust maneuver and lifting that mandible up off of the airway. So essentially, the tongue is attached to the mandibular structure, and by lifting up the mandible, then it is opening or lifting the tongue up off of the oropharynx. Suctioning is necessary if there's any type of blood, mucus, fluids, etc. You do not want to try to ventilate somebody or to keep an airway open if you have continuous fluids, because the potential is that they're going to get into their lungs. Blood and mucus, not as much of a significant impact to the lungs. If it does get in there, yes, they may have some difficulty afterwards. The worst thing, though, is to have any type of vomitus and or any type of food that actually gets into the lung fields, because it will cause significant pneumonias and infections in the patients. Portable suction units can be hand operated, and that's what we work with in class. If fixed equipment, it's essential for resuscitation. You need to have suction available. Those little electronic units, those are great. They suction really well, and they use standardized suctioning equipment with different size catheters. Whereas our portable suction units can be a little complicated. Really, it comes down to just knowing your equipment. So anywhere you work, make sure that you know where the suction is, how it works, and what the best way is for it to work. So you should have wide-bore, thick-walled, non-kinking tubing, which is common with all plastic rigid pharyngeal suction tips. We also call them Yonkauer catheters. Non-rigid plastic catheters, if you have a device that accepts those. Those are just long, thin tubes. Non-breakable disposable collection bottle. Again, all suction units are going to have something that the vomitus is sucked into, or the mucus or fluid, etc., is sucked into. And then water supply for rinsing the tips. You carry water supply in any of your sterile waters. You can just dip the tip into it. It really just kind of cleans it out, because it can get mucked up with yuck. Inspect your equipment regularly. Make sure that your suction unit is working. If you have a vacuum unit or a suctioning unit that is like battery operated or power operated, you want to make sure that the suction pressure of that is at least 300 millimeters over mercury. Select and attach the appropriate suction catheter to the tubing. Never suction the mouth or nose for more than 15 seconds at one time for an adult patient, 10 seconds for children, and 5 seconds for infants. And suctioning can result in hypoxia if done too long or too many times within an area. Of course, we want to clear out any of the major vomitus. We don't want that to go into the lungs. But again, 15 seconds at one time for adult patients, 10 seconds for children, 5 seconds for infants. Also, repeat suctioning only after the patient has been adequately ventilated and re-oxygenated. When patients have secretions or vomitus that cannot be suctioned easily, remove the catheter, log roll the patient to the side, i.e. the recovery position, clear the mouth carefully, very carefully, with a gloved finger. In fact, put something in between the teeth, like an OPA, something to give you just enough room that if the patient starts to close their mouth or starts to bite down aggressively, it'll give you enough time to get your fingers out. If the patient produces frothy secretions, as quickly as you can suction them, suction the airway for 15 seconds, ventilate for 2 minutes, and then continue that alternating pattern until all the secretions are cleared. Continuous ventilation is not appropriate if vomitus or other particles are present in the airway. So we're talking frothy sputum versus versus vomitus. Now, airway adjuncts are one of the many tools that a EMT has to address airway dysfunction. So they prevent obstruction by the tongue and allow for passage of air and oxygen to the lungs. These are called oropharyngeal airways, and they're referred to as OPAs. They keep the tongue from blocking the upper airway, and it makes it easier to suction the oropharynx if it's necessary. Oropharyngeal airways are indicated in unresponsive patients without a gag reflex. Apneic patients being ventilated by bag valve mask. Contraindications are conscious patients and any patient who has an intact gag reflex. So, how do I check a gag reflex? Well, one of the best ways to tell is called a flutter response. You basically brush your finger across the eyelashes of an individual, and if their eyelashes flutter, then they still have a gag reflex. If their eyelashes do not flutter, then they most likely do not have a gag reflex. So the other is that if that does not work or you're still not sure, as you approach applying the OPA and the patient begins to gag, then you don't continue to apply it. Okay. Nasopharyngeal airways are indicated for patients who is responsive or has an altered level of consciousness and needs airway support, and they have an intact gag reflex, and they're unable to maintain their own airway spontaneously. Nasopharyngeal airways are inserted via the nose. Indications include semi-conscious or unconscious patients with an intact gag reflex, patients who will not tolerate an OPA, and contraindications, very, very significant, severe head injury with blood in the nose or a history of fractured nasal bone, because that means their septum may be off and you can actually cause damage to the septum. Use the recovery position to help clear an airway in the unconscious patient who's not injured and is breathing on his or her own. Roll the patient onto either side so that the head, shoulder, and torso move all at the same time without twisting. Extend the patient's lower arm and place the upper hand under his or her cheek. Whenever you get into the skill where you apply a backboard to a spinal injured patient, if you get all the way through getting them on a spine board and you do it very quickly, then somebody begins to vomit, you can easily, very easily lift them up on their side so that the vomit does not get inhaled. Always give oxygen to patients who are hypoxic. Some tissues and organs need a constant supply of oxygen to function normally. And never withhold oxygen from any patient who might benefit from it. Supplemental oxygen equipment. Do become familiar with how oxygen is stored. Oxygen cylinders contain compressed gas. Liquid oxygen is becoming a more commonly used alternative, and that's because there's less change out required. You have more reserve in a smaller space, basically. When handling gas cylinders, do so very carefully. They're under significant pressure. Make sure the correct pressure regulator is firmly attached before transport. A puncture hole in a tank can turn into a deadly missile. Secure cylinders when stored on ambulance and when in use during transport. Never stand them up on a desk or on a table. Don't stand them up on the floor of the ambulance. Again, you want to protect the oxygen tank. Most importantly, you want to protect the top of the oxygen tank where the regulator is affixed to. Whenever we are working with the skill, then we'll be able to describe each of these components much more easily by demonstrating how the oxygen tank should be handled carefully, how a pin indexing system works, and those things that we need to be aware of when we're working with oxygen cylinders. Pin indexing system works with any tank that carries compressed gas, is specifically designed to fit with only one type of regulator. So you cannot accidentally pick up the wrong regulator or accidentally pick up the wrong tank and work with it. Every cylinder of a specific gas type has a given pattern and a given number of pins. Pressure regulators are used to help reduce the pressure out of the cylinder and provide gas via the flow meter to the patient based on what you set it at. So it reduces the cylinder's pressure to useful therapeutic range, usually 40 to 70 psi. Many of these cylinders will, on average, hold between 2,000 to 3,000 psi within the tank, and this will break it down to 40 to 70 psi. Final attachment for delivering the gas is either a quick connect female fitting or a flow meter. Flow meters are permanently attached to a pressure regulator on all EMS equipment. Pressure compensated flow meter If I say I want it to dispense 2 liters per minute, then it will dispense 2 liters per minute. If I want it to dispense 15 liters per minute, it will dispense 15 liters per minute. And they're very easy to use. And again, you'll see that in the skill as you're working with it. Hazards of supplemental oxygen include combustion and oxygen toxicity. Combustion does not burn. It's not a burn or explode, but it does speed up the combustion process. So if there's a fire, it will definitely make the fire burn hotter, brighter, stronger. Make sure the area is adequately ventilated and never leave an oxygen cylinder standing unattended. There's a little video in here. If you have a chance to look at this PowerPoint slide, you'll appreciate it. If you like those Mythbusters kind of videos, I mean, this guy's like amateur. He's definitely not Mythbusters, but he basically shows how the different oxygen concentrations burn with, how they improve combustion in something that is burning. It's pretty impressive to watch.
Hey everyone.
Not all patients need high concentrations of oxygen. It can have some detrimental effects, as we discussed before. When pulse ox is available, try to tailor your therapy to that 94% or above. Again, if somebody is in distress, you don't want to withhold oxygen, okay? If their skin signs, if their respiration is failing at the metabolic level, their oxygen carbon dioxide is not being exchanged, then high flow O2 is required. We have different types of oxygen delivery equipment, including non-rebreathing masks, bag valve masks, and nasal cannulas. The generally non-rebreathing masks are run at 10 to 15 liters per minute. Bag valve masks at 25 liters per minute, and nasal cannulas anywhere between 2 and 8 liters per minute. 2 and 6 liters per minute is more common. 8 and 10, they've been using with COVID in these special high flow nasal cannulas. So non-rebreather masks, preferred way to give oxygen in the pre-hospital setting for those patients who are significantly hypoxic. So patients who are breathing adequately but have hypoxia, considering nasal cannula first may get them to that 94% or above. Combination mask and reservoir bag system. Whenever we work with our non-rebreather masks, we'll discuss how to make sure that that reservoir bag is inflated before you actually apply it to the patient. Adjust the flow rate so the bag does not collapse when the patient inhales, and again, that's usually 10 to 15 liters per minute. When oxygen therapy is discontinued, remove the mask. Nasal cannulas deliver oxygen through 2 small tube-like prongs that fit into the patient's nostrils. It can provide 24% to 44% inspired oxygen when the flow meter is set at 1 to 6 liters per minute. It's usually recommended that for patient comfort that it's not set above 6 liters per minute. I highly recommend keeping it down at the 2 to 4 liters per minute is best for the patient to continue to keep them comfortable. Also, it is not uncommon with COVID to see patients being treated with a higher flow, like a 10 liter per minute higher flow nasal cannula. And this is for the long-term requirements for oxygen therapy for some of these patients. When you anticipate a long transport time, definitely consider using humidification. However, do be sure that that humidification component within the ambulance is cleaned out regularly and that the water is changed between patients. Because over a prolonged period of time, nasal cannula can dry or irritate the mucous membranes, and humidification helps to prevent that. A patient who breathes through the mouth or has nasal obstruction will get little to no benefit from a nasal cannula. Always try to give high flow through a non-rebreathing mask if you are required to do so because the nasal cannula is not working and the patient requires oxygenation. Partial rebreathing masks are similar to non-rebreathing masks, except there is only one-way valve between the mask and the reservoir. Patients rebreathe a small amount of their exhaled air, and this is advantageous if the patient is hyperventilating. The oxygen enriches the air mixture so that patients receive between 80 to 90% oxygen. To convert a non-rebreathing mask to a partial rebreather, remove the one-way valve between the mask and the reservoir bag. Venturi masks are used in that long-term setting. A number of attachments can vary the percentage of oxygen while a constant flow is maintained from the regulator. This is used to maintain oxygenation over a longer period of time. The Venturi principle causes air to be drawn into the flow of oxygen as it passes a hole in the line, so they're getting ambient air mixture in addition to oxygen supplementation. The Venturi mask is a medium flow device. It delivers between 24% to 40% oxygen, depending on the manufacturer. And again, it's useful in long term management of physiologically stable patients. A tracheostomy mask is used for patients with tracheostomies that do not breathe through their mouth and nose. Now, in the event you don't carry a specific tracheostomy mask, you can use a non-rebreather, and you can use a a mid breather type mask for tracheostomy patients. That will work just fine. Tracheostomy masks cover the tracheostomy hole. They have a strap that goes around the neck. It secures more tightly to the neck versus the uh, non-rebreather concentrator mask. But the airflow delivery for oxygen is going to be higher for these patients, regardless of the type of mask that you use. And if you're trying to oxygenate them, then that is your goal. Some EMS systems provide humidified oxygen during extended transport for certain conditions, such as croup, which we haven't talked about yet, but we will in our respiratory emergencies. Dry oxygen is not considered harmful for short term use. Many EMS systems do not use humidified oxygen in the pre-hospital setting, and a lot of that has to do with growth of bacteria and the risk that's involved in assuring that it's cleaned. Always refer to medical control or local protocols for guidance involving any patient issues. Probably the most important skill in EMS at any level is going to be basic airway and ventilation techniques that are extremely effective. Always follow standard precautions as needed when managing a patient airway, and do know that they will very likely be exhaling droplets, and you should be using droplet level precautions, i.e., you should be wearing a HEPA rated mask in addition to a pair of goggles and eye covering for any of your mucous membranes, in addition to gloves. Assisted and artificial ventilation techniques are probably the most important skill. Mastery of these techniques at the EMT level is imperative. We spend a lot of time working on our airway and breathing control skills. Patients who are breathing inadequately, too fast or too slow, are usually unable to speak in complete sentences. Fast, shallow breathing can be just as dangerous as very slow breathing. Remember to follow standard precautions as needed. Droplet precautions highly recommended when managing a patient's airway. Assisting ventilation and respiratory distress or failure, you must intervene quickly. So that means you really need to recognize it very quickly. The more experience you have, the easier it is to recognize this. Intervene quickly to prevent further deterioration. There's two treatment options: assisted ventilation and continuous positive airway pressure. The purpose of assisted ventilations is to improve the overall oxygenation and ventilatory status, that mechanical status of ventilating the patient. Again, working on the respiratory component or the respiration component is a little bit more complex. It is not necessarily something that an EMT level can do, or even ALS, to change the respiration component at the alveolar level. Signs and symptoms of inadequate ventilation include altered mental status, inadequate minute volume, excessive accessory muscle use, and fatigue. To assist a patient with ventilations using a bag valve mask, if they're conscious, explain the procedure to the patient. Place the mask over the patient's nose and mouth. Squeeze the bag each time the patient breathes, maintaining the same rate as the patient. After the initial 5 to 10 breaths, slowly adjust the rate and deliver an appropriate tidal volume. Adjust the rate and tidal volume to maintain an adequate minute volume. Patients in respiratory arrest need immediate treatment to live. We would also use a bag valve mask in this type of a situation. So there is the mouth to mask technique, which you learn in CPR. Not as recommended, but if that is all you have, maybe you're a first responder on a unit and you don't carry a BVM, but you do carry mouth to mask, one or two person BVM. And then there is the manually triggered ventilation device, which are not often seen in the field. However, occasionally you may run across a manually triggered ventilation device. Just be very careful with those because they have a tendency to overinflate the lungs. Artificial ventilations are necessary to sustain life, but are not the same as normal breathing. In normal breathing, remember we have a negative pressure, diaphragm contracts, pulls in the air into the chest cavity. Positive pressure ventilation, on the other hand, generated by a device, forces air into the chest cavity. With positive pressure ventilation, you also have increased intrathoracic pressure. So, because of that increased intrathoracic pressure, remember those organs in the mediastinum, right? So you have the heart and the great vessels. The pressure increases in the chest. That's going to compress on the heart and the great vessels, which can actually reduce the amount of blood that's being pumped to the heart, which will then reduce the amount of blood that's being pumped out of the heart. More volume is required to have the same effect as normal breathing, which pushes the airway walls out of their normal anatomic shape. Air is forced into the stomach. That's an unfortunate event because gastric distension is caused, and then vomiting and then aspiration may follow afterwards. The EMT must regulate the rate and volume of artificial ventilations to help prevent the drop in cardiac output. So, to make sure that you are following the correct rate, adult would be one breath per 5 to 6 seconds. A child would be one breath per 3 to 5 seconds. And an infant is one breath per 3 to 5 seconds. Now, notice that 5 is in all of those. If you remember, the adult, the child, and the infant should have a breath every 5 seconds, then you fall into each of those parameters. Mouth to mouth and mouth to mask ventilation is often a barrier device, is used routinely because people will throw up whenever they are in cardiac arrest, and or if they're apneic, and or if somebody has been ventilating them already. So a plastic barrier with a one-way valve is often placed on the patient's face. Mouth-to-mouth ventilations without a barrier device should be provided only in extreme situations, and most often mouth-to-mouth is found whenever a family member or a child or infant have been affected and required ventilation. Stranger to mouth is not very common at all. If you decide to assist a stranger that has collapsed in front of you, don't feel that you are obligated to provide mouth to mouth. Only consider doing compressions. If that is all that you're capable of or comfortable doing, then do the compressions, because just compressions alone will make a difference in the outcome. A mask with an oxygen inlet provides oxygen during mouth-to-mask ventilations. We have mouth-to-mask ventilation equipment here that you'll be using for your CPR skills. It supplements air supplied by your lungs if you're able to connect it to oxygen. The gas you exhale still contains about 16% oxygen, so it's not extremely oxygen deprived. With the mouth-to-mask system, patients get the benefit of significant oxygen enrichment. The system frees both the EMT's hands to help better with the airway and open and provide a better seal between the mask and the face. Signs of adequate ventilation include that the patient's color is improved, the chest is rising adequately, there's no resistance when ventilating, or you hear and feel air escape as the patient is exhaling. To increase the oxygen concentration, administer high flow 2 at 15 liters per minute through the oxygen inlet valve of the mask. Combined with your exhaled breath, this will deliver about 55% oxygen. The most common method used to ventilate patients in the field is the BVM, the bag valve mask. With an oxygen flow rate of 15 liters per minute, often set at 25 liters per minute, a BVM can deliver nearly 100% oxygen. It can deliver only as much volume as you can squeeze by hand. The goal is not to squeeze the entire bladder. The goal is to give one very strong squeeze on the bladder of the BVM. It does provide less tidal volume than mouth-to-mask ventilation, but it delivers a much higher concentration of oxygen. So an experienced EMT can provide adequate tidal volume. As a new EMT, develop proficiency by ventilating airway training mannequins before using a BVM on a patient, and we will definitely be doing a lot of that in our skills. If you have difficulty adequately ventilating a patient with a BVM, switch immediately to another method. Don't mess around with it. Use the mouth to mask technique if it's necessary. Even a non-rib breather on a patient that's not breathing will deliver some level of oxygenation during CPR. BVM components include a disposable self-refilling bag, no pop-off valve or disabled pop-off valve. Those are used more for infant resuscitation, neonatal resuscitation. A non-rebreathing outlet valve, an oxygen reservoir that allows for delivery of high concentration O2, one-way no-jam inlet valve with a flow of up to 15 liters per minute, transparent face mask. It offers the capability of performing under extreme heat or cold. Total volume in a BVM, for example, would be a 1,200 to 1,600 milliliter. 500 to 700 milliliter for pediatric, and infant is 150 to 240 milliliters. The volume of oxygen delivered is based on observing chest rise and fall. Only means of assessing tidal volume in the field is watching the rise and fall of the chest. When using a BVM with high flow O2 on an adult patient, squeeze the bag just enough to cause a noticeable rise of the patient's chest. This is about 600 milliliters. By delivering just enough tidal volume to see the chest rise, the risk of gastric distension and associated complications is reduced. It is impractical for EMTs to accurately measure tidal volume in millimeters per kilogram in the field. The key is to watch for good chest rise and fall. Let this determine the appropriate amount of volume to deliver. Whenever possible, work together with your partner to provide BVM ventilation. One EMT maintains a good mask seal, the other EMT squeezes the bag. To use the one-person technique, select the proper size mask, kneel above the patient's head, maintain the patient's neck in an extended position unless there is a cervical spinal injury, in which case you'll be doing the modified jaw thrust. Open the patient's mouth, suction as needed, insert an oral or nasal airway to maintain airway patency, place the mask on the patient's face. Make sure the top is over the bridge of the nose and the bottom is in the groove between the lower lip and the chin. If the mask has a large round cuff around the ventilation port, center the port over the patient's mouth. Inflate the collar for a better fit and seal to the face if necessary. Create a seal using the EC clamp method. Bring the lower jaw up to the mask with the last 3 fingers of your hand and maintain an open airway. Squeeze the bag with your other hand until you see adequate chest rise. If you are working with 2 EMTs, one would hold the BVM mask in place while the other squeezes the bag. Again, one ventilation every 5 seconds is just a standard. And for the next 5 to 10 breaths, slowly adjust the rate and deliver tidal volume until adequate minute volume is achieved. When using a BVM or any other ventilation device, do be alert for gastric distension. You'll see the abdominal area start to inflate. Whenever it gets to a certain point, it will force the contents of the gastric stomach out into the mouth, and then the patient will need to be suctioned and or log rolled so that the vomitus can leave. To prevent or alleviate the distension, make sure the patient's airway is appropriately positioned, ventilate at the appropriate rate, ventilate at the appropriate volume. If the stomach appears distended, recheck and reposition the head and perform rescue breathing as needed. Passive ventilation is the process of expansion and contraction of the chest, creating a pump for air movement in and out of the chest. During cardiac arrest, we are performing basically passive ventilation, which is why ventilating a patient is not nearly as significant as actually doing the compressions. So chest wall movement assists in the ventilation process. Placing a non-rebreather on a patient in cardiac arrest will only increase the oxygen saturation of any of the air that is drawn in via this expansion and contraction from creating the pump air movement. Manually triggered ventilation devices, also known as flow-restricted oxygen-powered ventilation devices. They allow a single rescuer to use both hands to maintain a mask-to-face seal while providing positive pressure ventilation. It does reduce rescuer fatigue. However, there are some disadvantages, including being difficult to maintain adequate ventilation without assistance. Should not be used routinely because of high incidence of gastric distension and damage to structures within the chest cavity. It requires a special unit, and additional training are required for infants and children. It shouldn't be used with COPD or suspected cervical spine or chest injuries. Peak flow rate of 100% oxygen at up to 40 liters per minute. Inspiratory pressure safety release valve. An audible alarm that sounds when you exceed the relief valve pressure, because then you are at risk of actually causing damage to the lungs within the chest. As with bag valve masks, you must make sure there is an effective seal between the patient's face and mask. The amount of pressure required varies according to patient size, lung volume, and lung condition. A COPD patient, for example, will need greater pressure, but it shouldn't be used in patients that have COPD. An automatic transport ventilator is frequently seen on BLS transport units. It is certainly a totally capable skill that an EMT can perform. Do be very, very informed about the equipment that you carry and how it works, making sure that you are delivering the appropriate tidal volume for the weight of the patient. A CPAP machine is a device that we will get to participate with in our skills. CPAP is continuous positive airway pressure. Many people diagnosed with obstructive sleep apnea wear a CPAP unit at night to maintain their airways while they sleep. We also use CPAP for situations like pulmonary edema because it assists in pushing the fluids back down into the vessels where they belong. CPAP increases pressure in the lungs. It opens collapsed alveoli, pushes more oxygen across the alveolar membrane, and forces inside fluid back into the pulmonary circulation. Therapy is typically delivered through a face mask that's held on the head with a strapping system. A good seal with minimal leakage between the face and mask is essential. Many CPAP systems use oxygen as the driving force to deliver the positive ventilatory pressure to the patient. Do use caution with patients with potentially low blood pressure because CPAP causes a drop in cardiac output. And if you remember how we talked earlier about the increased intrathoracic pressure, then you can understand that increased intrathoracic pressure squeezes the great vessels in the heart so that the cardiac system is not able to bring in as much blood nor pump as much blood out of the heart into the body. This causes a drop in blood pressure. So it's one of the things that you're looking for when you are using a CPAP is the patient's blood pressure and how stable the patient's blood pressure is. Depending on where you start on the CPAP level, you may be able to back off and increase the blood pressure again, but ultimately you may have to remove the CPAP machine altogether. It's indicated for patients that are alert and able to follow commands. It displays obvious signs of moderate. Any patient that displays obvious signs of moderate to severe respiratory distress from a condition such as pulmonary edema or obstructive pulmonary disease. The patient is breathing rapidly, such that it affects overall minute volume, and the pulse oximetry reading is less than 90%. Contraindications are a patient that is in respiratory arrest. No, we cannot apply this to a cardiac arrest patient in order to control airway and provide ventilations. Signs and symptoms of pneumothorax or chest trauma are also a contraindication. Patients who have a tracheostomy, contraindication. Active GI bleeding or vomiting. A patient who's unable to follow verbal commands. And always reassess the patient for signs of deterioration, respiratory failure, and or low blood pressure or lowering blood pressure. Components of a CPAP unit are quite extensive. They include a generator, which often is attached to an oxygen tank, and that is the generator for the positive pressure ventilation, a mask, a circuit containing corrugated tubing, a bacterial filter, a one-way valve. Additionally, sometimes they have an attachment component that allows albuterol to be attached. So a paramedic ALS would be able to attach nebulized albuterol treatment into the CPAP, which then helps to force rescue medication into the patient. The CPAP generator creates resistance throughout the respiratory cycle. The resistance creates a back pressure in the airways that pushes open the smaller airway structures like bronchioles and alveoli. The amount of pressure can be determined by adjusting a valve with a CPAP system or with a separate valve that can be attached. The pressure of 7 to 10 is generally an acceptable therapeutic range. Most CPAP units are powered by oxygen, so it's important to have a full cylinder of oxygen when using CPAP. Disposable CPAP devices are lightweight and relatively easy to operate. And to use the CPAP, we will be looking at our skills sheet, or not skill sheets, but we will be performing this skill in skill session. Complications, a lot of patients actually find CPAP to be claustrophobic and they'll resist application of the mask. Oftentimes, if you're talking to your patient, you can actually coach them through the process rather than forcing the mask on them. Due to the high volume of pressure generated by CPAP, pneumothorax is a risk. High pressure in the chest can lower the patient's blood pressure. If the patient shows signs of deterioration, remove the CPAP and begin positive pressure ventilation using a BVM attached to high flow tube. Special considerations in airway control include stomas and tracheostomy tubes. Patients who have had a laryngectomy, surgical removal of the larynx, have a permanent tracheal stoma, which is an opening in the neck that connects the trachea directly to the skin, also considered a tracheostomy. Patients may have other openings in the neck depending on the type of operation performed. Ignore any opening other than the midline tracheal stoma. It is the only one that can be used to put air into a patient's lungs. Neither the head tilt, chin lift, nor the jaw thrust maneuver is required to ventilate a patient with a stoma. Also, they often hide them in public by wearing scarves or other clothing that buttons up across the stoma so that it's not an obvious hole in the chest or in the neck. If you go to ventilate a patient and you notice they have no rise and fall, even though you're absolutely certain that you are doing the procedure correctly, it serves to do a quick assessment of the neck to see if you're missing a stoma. A standard 15-22 millimeter adapter on the BVM will fit into the tube in the tracheal stoma. Use 100% oxygen attached directly to the BVM. If the patient has a stoma but no tube is in place, you can use a very small infant or child mask, make a seal around the neck and the opening of the stoma, seal that around there, and then use the BVM to ventilate. If you have a hard time ventilating a patient with a stoma, try suctioning the stoma in the mouth with a French or soft tip catheter. Seal the stoma, so actually cover up the stoma and see if you're able to move air via mouth-to-mouth ventilations or mouth-to-mask in the EMT's case. In foreign body airway obstruction, if an obstruction completely blocks the airway, it is a true emergency. It will result in death. In an adult, sudden foreign body airway obstruction usually occurs during a meal. In a child, it can occur at any time because they put everything in their mouth. By far, the most common airway obstruction in an unconscious patient is the tongue that relaxes and falls back into the throat. Causes of airway obstruction that do not involve foreign bodies include swelling from infection or acute allergic reaction. Repeated attempts to clear the airway could be dangerous. In fact, you can push the bolus down even farther, making it more difficult to retrieve or to remove. These patients do require specific emergency medical care and will continue to perform chest thrusts, the Heimlich maneuver, basically until they're unconscious, and then we will transfer over to cardiopulmonary resuscitation. So recognizing the universal choking sign is pretty universal. Everybody that starts to choke actually does do the same thing. If they have any noisy breathing or they're coughing, then they do not have a complete obstruction. They should be encouraged to cough forcefully. A Heimlich maneuver should not be performed on these types of patients. Again, if they are coughing or speaking, or they are able to breathe through, again, encouraging them to cough out the obstruction and then being alert for the possibility that it does become a full obstruction. With good air exchange, the patient can cough forcefully, although you may hear wheezing between coughs, and that's because there's inflammation and mucus production because the airway is trying to remove anything that is causing a problem. As long as the patient can breathe, cough forcefully, or talk, you should not interfere with the patient's efforts to expel the foreign object on his or her own. Continue to reassess the patient condition and expect that if it does not clear, that it could become worse. With poor air exchange, the patient has a weak, ineffective cough and may have increased difficulty breathing, stridor, and cyanosis, high flow O2, while you try to encourage them to actually, again, cough out the bolus. In severe airway obstruction, the patient has the universal choking sign, they can't breathe, talk, or cough. This patient really does need quick intervention, and you need to start providing what we have always called the Heimlich maneuver. If the obstruction is not cleared quickly, the amount of oxygen in the patient's blood will decrease dramatically. But don't assume that just because the patient is unconscious that it is because of an airway obstruction. There are lots of other causes of unconsciousness and respiratory failure. If the patient is unresponsive, not breathing, and has no pulse, begin CPR with chest compressions. Emergency treatment includes the head tilt chin lift to clear the tongue of the obstruction. Large obstructions that you can see should be swept forward out of the mouth with your gloved index finger. Put a bite block in there. Make sure there is something to protect your finger in the event that they start to clench down. Abdominal thrusts, aka the Heimlich maneuver, are the most effective method of dislodging and forcing out an object. Once a patient becomes unconscious, unresponsive, and doesn't have a pulse, you no longer perform abdominal thrusts, and instead you begin CPR. Dental appliances are important for the structure of the mouth and for using airway adjuncts. If a well-fitting denture is in place, or a well-fitting crown or bridge is in place, do not remove the appliance if you can avoid it. If it is not in place, it will become an obstruction and you do need to remove it. Again, be cognizant of what is happening to that particular device. You want to make sure that it is in good care and that it's not going to get damaged or destroyed or lost. Facial bleeding can cause airway problems, especially with fluid in the airway. So remember to suction and to control by direct pressure. For example, if you have a laceration to the soft palate or a laceration to the hard palate, maybe even a fracture on the inside hard palate, that you can and should hold direct pressure on that area to try to control the bleeding. And then, of course, suction is necessary. So in class, we will be covering this video. This video is related to implementing a CPAP machine. It's a really good video to follow. It describes that process a little bit more. We will be using some hands-on with a CPAP machine so that you can see more clearly how to apply that. Additionally, please be sure to complete at least a page of notes on this chapter. This is a really long chapter, and or your workbook for this chapter, and we will see you during class.